Good afternoon, everyone. It is my pleasure to welcome you to our information session today on the recent modification for flexibility on the 2014 Certified Electronic Health Records Technologies that was published by the Centers for Medicare and Medicaid Services on August 29th. My name is Brett Campbell. I'm the Communications Manager at the Massachusetts eHealth Institute, MeHI, and I'm serving as your facilitator today for this webinar. Okay, so at this time, I'd like to turn it over to Al Wroblewski, our Client Services Relationship Manager here at MeHI.
Thank you, Brett. We're happy to be here and give you the information I'm sure you're all looking for regarding how to approach this final rule that came out from CMS. I want to just make a few comments about the final rule because it potentially could be a little bit confusing. What CMS has done has actually sort of combined two different rules into one final rule. What I mean by that is there was an interim final rule issued on December 7th, 2012, and there's little bits and pieces. I'll basically just mention very briefly what's involved with that because it really isn't pertinent to the main issue here. On May 23rd of 2014, the proposed rule that we're all most interested in was issued by CMS and then finalized last week. And that's the main thrust of this. So if you're looking at the actual final rule, it may seem a little bit confusing because there's a few pieces from other legislation that is included in here. And so you want to pay attention to what's section Roman numeral 3, which is the proposed rule that we're most interested in. The other one, just to get that out of the way, basically dealt with some issues around EHR lab reporting for the hospitals, clinical quality measure thresholds for the hospitals, and then some technical standards around the data element catalog. So that basically was finalized. So, okay, so that's out of the way. So we're really going to talk about the rule that, proposed rule that came out in May and has been finalized. So I'd like to start out by turning it over to my colleague, Thomas Bennett, who will give you a little bit of the background about MeHI and a little bit of the focus of what we're hoping to accomplish today. Thomas?
Thank you, Al. I'm going to tell you a little bit about MeHI, Al mentioned. But before I do that, I'm going to talk to you a little bit about the overall organization and start the umbrella under which MeHI falls, and that is Mass Tech. You can look at your graph on the screen now. Mass Tech is a public economic development agency which focuses on supporting innovation and economic opportunity within the state's technology sector. And through, as you can see on the slide here, through the Innovation Institute and its two major divisions, Mass Broadband Institute as well as MeHI, a number of projects and initiatives are underway which revolve around collaborating with industry leaders, stakeholders across academia and government, growing businesses within the tech growth sector, expediting the adoption and use of technology throughout the state, developing industry clusters, connectivity, and a whole host of other initiatives going on, along with supporting and funding research. With that, I'll move over to specifically to the Innovation Institute, which, as you can see, has a host of initiatives it's driving. And one example of that, you can see at the top there, is the Mass Tech Hub Collaborative. And that initiative is just one that supports and grows the state's tech sector overall, and whose executive committee partners with entrepreneurs, CEOs, state officials, and industry organizations to strengthen all aspects of the state's tech innovation economy. And you can see there are others there as well. The Innovation Index, which is a publication which you guys have probably followed on a regular basis, as well as the Mass Big Data Initiative. That is, just as the title states, it's all about big data, and using data-driven knowledge to inform business decisions as well as economic change. Moving over to the Massachusetts Broadband Institute, or MBI, they work extensively to extend affordable high-speed internet access to all homes, businesses, and other public places across the entire Commonwealth. A couple of initiatives that I think are worth mentioning, of course, is the Mass Broadband 123, which is a network which was built to spread broadband connectivity across western and north central Massachusetts specifically. And there are others as well. You can see there broadband mapping, adoption. Another I'd like to note is the Mass Vets Advisor, which connects veterans and their families to resources they need and makes more efficient the online access to veterans services. Okay, and then now here we are, MeHI, the Massachusetts eHealth Institute. MeHI is the designated state agency for Medicaid services, and we're all about coordinating, accelerating, promoting, and advancing healthcare innovation, the adoption of health IT, and making sure that every healthcare provider across the Commonwealth is meaningfully using health IT and electronic health record technology. And next, I'd like to talk a little bit more about MeHI, and that, you know, there are some new things coming across the horizon, and a lot of that revolves around e-health services and support. And looking at the slide now, it's a comprehensive sort of package of support to all healthcare providers in achieving meaningful use of electronic health records technology. And that support includes meaningful use gap analysis, registration and attestation support, secure document storage and audit preparation, as well as support providers with physician quality reporting system, PQRS, and that entails as well a qualified registry for submitting PQRS measures. And lastly, collaborating with external partners to offer patient engagement resources, privacy and security tools, and other health IT resources. And there's a lot more to come with that, and we'll be getting messages about that in the coming weeks. And with that, I will move to the next slide, which is goals of today's session. And number one, providing information about the final rule as it relates to the Medicare and Medicaid EHR incentive payment programs. Provide some clarification around key components, as well as give you guys a chance to ask any questions that you might have. And with that, I will send it back over to Al.
Thank you, Thomas. I want to sort of give a little bit of the landscape of how this whole process works. We're always sensitive to people who are not familiar with all the jargon and acronyms and so forth, so we don't want to make any assumptions that everybody knows what all these combinations of letters mean. Basically, at the Health and Human Services level in Washington, you have two different offices that are impacting the incentive payment program. The ONC, Office of the National Coordinator for Health Information Technology, is really the tech side. In other words, they're setting the standards for the EHR performance, and very, very focused on developing the functional aspects of the EHR so that it can, in fact, perform according to the goals and objectives of improving healthcare. The CMS, the Centers for Medicare and Medicaid Services, handles the actual measures, meaningful use measures, and the actual operation of the EHRs in the clinical setting. So these two arms of Health and Human Services work together in terms of really leveraging the power of technology. This particular rule, as you can see on the slide, was a collaboration of CMS and ONC. In September of 2012, they each issued their own set of final rules, which was interesting. It was the same day. So one of them dealt with the actual processes, meaningful use measures, and so forth by CMS. The other, ONC, spelled out the specifications that the technology, the EHR, software, hardware, all of it, had to meet by 2014. So on the ONC side, that rule in 2012 set the specifications for something called the 2014 edition. So the new specifications were released in September of 2012 with the expectation that all providers would be using the certified EHR technology, meeting the standards set, it's called the 2014 edition. So a lot of what this rule it really comes out of is that was a very, very ambitious goal, and there have been a number of obstacles to achieving that goal, so that everybody on January 1st of this year would be up and running on the new technology. So that created a number of issues where basically one of the modifications was to have a 90-day reporting period for 2014 to take some of the pressure off, as many people ordinarily would be doing a 365-day reporting period. But even that wasn't enough. And so the proposed rule that was offered in May of this year really expanded some aspects of flexibility or modification or relief, or however you want to look at that, to give people a little more room to fully implement and utilize the 2014 edition of their EHRs. To read the very last line there, the backlog of many months for updating version. I'm sure many of you could tell very rich stories about your experiences with vendors, and even within your own shops, the whole process of getting everyone up to speed and using it correctly has been a significant challenge. So this final rule we're talking about just came out last week, and it really is focused on the incentive payment program. So we're talking both about Medicare and Medicaid, a little bit about the hospital, but primarily about EPs, eligible professionals. The incentive payment program really is designed to go in two directions: one, the hospitals as institutions, and then eligible professionals as providers on the ambulatory side. So the final rule, one of the challenges of the final rule, it often speaks to both eligible professionals and eligible hospitals. Another complexity is it speaks to both Medicare and Medicaid. In fact, there are some differences between the two programs, Medicare and Medicaid, and there are also differences between the eligible professionals and eligible hospitals. So that makes interpreting the final rule a little bit challenging, because you have to sort of figure out how does it apply for my particular circumstances. So the idea of this rule is essentially to allow some flexibility, and you see that term that I referenced before, the 2014 edition. The goal was everybody, both hospitals and the ambulatory side, would be up and running on that version as of January 1st for the eligible professionals, or October 1st of 2013 for the hospitals. The hospitals use the federal fiscal year of October through September, and the eligible professionals are linked to the calendar year. So the 2011 edition, that was the last rule setting by ONC, where they set the standards in 2011. So those are the two different versions that we're considering here. The 2011 edition, which are set to those standards, and then the 2014 edition standards, which were established in August of 2012. One of the things that CMS was emphasizing is they didn't want people to sort of buy an obsolete package. So they kept the adopt, implement, upgrade aspect, which is only for the Medicaid program. So the first year, if you commit to using certified EHR technology, you can get your first year payment. So one of the things that the rule emphasizes is even though you can attest to meaningful use using the older version, the 2011 version, you cannot do similarly for adopt, implement, upgrade. You have to show that you are committed to using the new 2014 version. Starting January 1st, 2015 for the eligible professionals, or October 1st of 2014, all the EPs, eligible professionals, eligible hospitals must attest using the 2014 edition EHR. Now, this is probably one of the most controversial aspects of this final rule, because if you think about it, if you're being permitted to use the older version, 2011, and you attest, say, the last 3 months, you're an eligible professional, October, November, December, then as of January 1st, you're required to have the new version up and running, the 2014 version. How exactly people are going to do this is unclear. I think it's going to be sort of a unique New Year's Eve for many people trying to get this up and running, because the reporting period for 2015 will be 365 days. So you have to, be up and running and have, drug formulary checks, drug-to-drug allergy checks. All of that has to be enabled as of January 1st. Clinical support rules, all of those meaningful use measures. So how that's going to play out will be, quite interesting to see, because it's posing quite a challenge. So there was a lot of pushback on that. However, CMS rejected the idea to go to a 90-day reporting period in 2015. The last one, Stage 2, which was designed to be replaced, or basically that Stage 3 would be introduced in 2016, that was pushed back to 2017. A piece of confusion that I've experienced quite a bit is simply because the rule now exists, in other words, Stage 2 exists, doesn't mean everybody immediately goes to Stage 2. It's a sequential process. So you have to go through the various stages of Stage 1, Stage 2, and then Stage 3. So people can be at different points in the spectrum of stages. What this means is Stage 2, for those who choose to continue meeting the Stage 2 measures for 2014, would have an additional 2 years. So in other words, 3 years of Stage 2, 2014, 15, and 16. So that's something just to keep in mind, that just as Stage 1 has been extended, that people can have actually a maximum up to 4 years, depending on how soon you started with the Medicare program of Stage 1. So it doesn't mean that you are required to have a particular number of years because of all these changes that have been introduced. Okay, in 2012, again, that's where the Stage 2 final rule took place. This is something to pay attention to in terms of terminology. The rules for Stage 1 that were in effect in 2013 are called the 2013 Stage 1 Objectives and Measures. The rules that take effect in 2014, requiring the use of a 2014 edition certified EHR, are called the 2014 Stage 1 Objectives and Measures. So keep that in mind, because I know there's a lot of lingo and technology terms and everything here that makes it complicated, but it's important to recognize which Stage 1 objectives and measures are of relevance to you. So the key here is you can, in fact, attest to the 2013 Stage 1 objectives and measures if you have the old version, 2011 edition. And providers who are allowed to attest using the 2013 standards, doesn't matter what you were going to attest to this year, whether it be Stage 1 or Stage 2. Okay, so in your first or second year of Stage 1, you can you have a choice. You can go either, again, with the 2013 Stage 1 objectives and measures, or the 2014. And as you see, it really is driven by which EHR you're going to be utilizing. Individuals, providers, this is true with the hospitals as well, in their first year of Stage 2 in 2014 can attest either to the 2013 or 2014 Stage 1 objectives and measures for stage 2. So you have the greatest flexibility if you were scheduled to complete stage 2 in 2014. The note, the asterisk there is actually, it's in the final rule, but actually is not of great significance because the beginning of stage 3 has been postponed to 2017. So it isn't as if, if you were supposed to do stage 2 this year and next year, 2015, was your second year, and then 2016 you'd start stage 3, then that would be significant. But coupled with the postponement of stage 3, it's not of particular significance. Here's a little schematic just showing what the different options are. And I won't go into this in detail. We did, go over this pretty much when we did the webinar on the proposed rule. It gives you flexibility. Again, it's really driven by your particular situation in relation to the EHR you have installed and up and running in your particular setting. Here is another schematic showing the number of years you can attest to different stages. If you look at the first one, which is actually quite interesting, you can, in fact, do 4 years of stage 1, 11, 12, 13, and 14. And then because this year you can go either way with stage 1 or stage 2, you could, in theory, do 3 years of stage 2 in 2014, 15, and 16. So originally the program was set up that you do 2 years of each stage, but because of all these changes and modifications, it's really, created a situation where you may, in fact, do multiple years of any particular stage. Okay, here are some of the hot topics, I guess I would say, that are of particular interest in terms of reading through the final rule and understanding some of the implications. The reporting periods, CMS was pretty adamant about this. They said we have not tampered with the reporting periods. So basically what it is, for all Medicaid eligible professionals, it's a 90-day reporting period, any continuous 90 days. For first-time Medicare applicants, the same rule applies, any 90 days. For Medicare applicants in their second, third, or fourth years, it's any calendar quarter. So that's January through March, April through June, July through September, and October through December. One point of confusion regarding which period you are entitled to use is this final rule becomes effective October 1st. And some people incorrectly believe, oh, okay, so we really have to pick the last quarter. Not true. The effective date of the legislation is independent of the provisions of the legislation. So you can use any period in 2014 for your reporting period, again, driven by those particular requirements of whether you have a 90-day or a calendar quarter. As I mentioned earlier, the 365-day reporting period in 2015 is across the board. The only situation where that would not apply is if you're in the Medicaid program, and that would be your very first year of meaningful use, and you'd have a 90-day reporting period. But anybody who has attested previously to meaningful use would have a 365-day reporting period required to use the 2014 edition. So again, I'm not sure what we'll be hearing from CMS regarding, additional difficulties people will have converting from their 2011 version to the new 2014 version, basically overnight, December 31st. But as they say, more to come. MU measures. What's the impact been on MU? MU stands for meaningful use. Meaningful use is the terminology which is basically saying, look, we can leverage the power of health information technology to improve patient care and safety, reduce costs, and do a lot of wonderful things around healthcare. And so there is this collaboration between the technology, the certified EHR technology, and the practice, what the practice actually does. So one of the interesting aspects of this legislation is how they approach the transition of care requirement, which is a stage 2 requirement, which requires that the eligible professional who transitions, actually hospitals as well, refers their patient to another setting of care, provider of care, provides a summary of care record for more than 10% of such transitions and referrals, either electronically to a recipient or where a health information exchange is used. So it's a requirement. The terminology is called interoperability. Interoperability means you're going from one system to another, and it's the exchange of data electronically. So what has happened here, because the whole point of this legislation is if you have not been able to fully implement the 2014 edition, then you are eligible to pursue some of these other options. Well, for this particular measure, it's not your EHR that we're looking at. Let's say, you upgraded to the 2014 version on January 1st and you're humming along. But the only way you can meet this measure is if other people have also upgraded, other institutions, other trading partners. And what we're finding is a number of institutions, clinics, practices, so forth, have not been able to meet that requirement of being able to receive the electronic exchange of the transition of care. So what CMS has said, okay, that is an impediment to implementation, even though it's not with your EHR, it's with somebody else's, and you are now eligible to take advantage of some of these options. So it's a very interesting interpretation of delays and problems with implementation, because it's no longer about yours, that you were all set to go, but it's about other people, because a big part of the goal of meaningful use, the incentive payment programs, is interoperability, the exchange of data in a timely fashion to improve healthcare. So that's an important one to keep in mind. So if you are in stage 2 and, let's say you did not have significant issues around implementation of 2014 version, if you are having trouble meeting this measure, you are eligible to essentially do a stage 1 2014 objectives and measures instead of continuing with stage 2. In the clinical quality measure area, there are no changes. Everything remains pretty much the same. One of the issues, again, there's a difference between the Medicare and Medicaid in terms of reporting. In Massachusetts right now, there is no electronic reporting of CQMs. At the federal level, there is, and therefore the clinical quality measures have to be part of your attestation. So you don't have the option at this point to do electronic reporting. Hopefully that'll be coming next year. The supporting documentation for the delays or hardships, it's interesting. The final rule is a little bit, what would I say, kind of generous in saying that if you attest to Medicare, you do not need to provide supporting documentation. Okay, so that's what the final rule says. On the other hand, you definitely want to have it. You want to have supporting documentation should you be audited. And that's, a critical piece of this legislation is saying if you have had no delays or any problems with implementation of the 2014 edition, you cannot take advantage of these options. So you have to demonstrate that there has been a significant holdup in the implementation. So what does implementation mean? In terms of the conversation, discussion language in the final rule, it really is not simply that it has not been installed. It also means that its functionality has not been at a level that allows you to capture all the meaningful use measures and to generate the reports and to have a level of confidence that, one, the EHR is in fact recording what is going on clinically. So it isn't simply that, it hasn't arrived. The truck hasn't pulled up to the door and you've unloaded it, installed it, flipped the switch. It really is about the functionality and capability. Has it met that? Another aspect of that is timing, the effort it takes to train your staff to get everybody up to speed, all the departments and your clinical team really using it correctly. That's another aspect of the delay. So if you look at it, if you received it in October of 2013, it's going to be, you're going to have a hard case to make that, delays and other things really prevented you from finding a 90-day period in 2014 to a test using your 2014 edition. So keep that in mind that that's going to be an important piece. On the Medicaid side, because the Medicaid side has a different approach from Medicare, which is to facilitate you having a lot of backup documentation ready to go before you complete your attestation process with Medicaid. So there's a need for supporting documentation up front. So that'll be part of the supporting documentation you should expect for those of you who are applying through Medicaid. Hardship exceptions, refers to the payment adjustments at Medicare. The same thing that occurred this year, which was if you had reasons that would prevent you from attesting, you can in fact apply for a hardship exception. So next year, if you applied by July 1st and April 1st for hospitals, then you would, and assuming it would be affirmed, then you would avoid payment adjustments in 2017. There are some aspects in terms of multiple locations. I know this is has been challenging for a number of people, but I'll just read this very briefly to give you an idea of the terminology. And again, feel free to call us and we can work with you on this if there are issues. Because you're going to have multiple locations and potentially different locations are at different places in terms of using certified technology. So if eligible professional uses different editions of the certified EHR at multiple locations, he or she may choose to use the alternate certified EHR option that is best applied for his or her patient encounters across all locations during the reporting period. However, these eligible professionals should then use the data from all patient encounters which occur at a location equipped with any edition of certified EHR technology, just as the eligible professional would use the patient data from all locations equipped with the certified EHR to meet meaningful use in any other year. Over 50% of the EP's patient encounters during the EHR reporting period occur at a location equipped with the new 2014 edition, which has been fully implemented. The EP would not be eligible to use the flexibility option in this final rule and should therefore limit their denominators to only those patient encounters in locations equipped with fully implemented 2014 edition. So please feel free to contact us on that, because that obviously is going to have particular implications in each situation. Immunization public health reporting, as it's stated here, is that if you did send in a test message last year, you simply need to reference that. That's in the CMS final rule. It's always state specific, so it depends a lot on the Massachusetts Public Health Department. And as we understand it, there are issues around relying on last year's acknowledgement letter, email saying, okay, you did a test, because the idea of this really is, of course, to just get ongoing reporting. Reasons for delaying to stage 3 into 2017, I just want to touch on that a little bit. It's to allow CMS and ONC to focus their efforts on the successful implementation of the enhanced patient engagement, interoperability, and health information exchange requirements in stage 2. So part of it is the data is not really there yet on stage 2, and so they really want to learn from widespread utilization of stage 2. And as I mentioned, the data is also an important piece to inform the policy decisions for stage 3. So that's some of the reasoning for pushing that back to 2017. Two final points. The final rule says you are not going to be subject to any additional audit scrutiny by choosing one of these options. So it does not automatically flag you for an audit. The last point, which I wish I would have an answer to, but I want to raise it because I suspect we'll get it on the questions anyway. When can we attest? When can we attest using the other options in terms of 2011 edition? One of the questions which I've already passed on the CMS is, okay, this becomes effective October 1st. You set a deadline of October 1st for people to attest for Medicare and actually Medicaid as well to avoid the payment adjustment for next year. Can we attest using the 2011 version on October 1st? So I wanted to ask that question first because I know somebody out there is going to ask it. We don't have the answer at this point, but it will be something to keep in touch with us. In the final rule, there was a lot of concern issued from the states saying, hey, this is going to take a lot of work to get all of our systems up and running for all these options. CMS said, well, we're still going to go ahead. Didn't seem to make any difference. So it will be a challenge, and please keep in touch with us and Medicare and Medicaid incentive payment program to find out exactly how that's going to be handled. Definitely a significant complication. The final rule, press release, the final rule was published yesterday in the Federal Register, so you can get it there as well.